Good afternoon, everybody. My name is Christoph Stremicus. I'm the Director of the Market Analysis and Insight Program at the California Healthcare Foundation. CHCF is an independent nonprofit philanthropy dedicated to improving the healthcare system for Californians with low incomes and others who are not well served by the status quo. Today is a particularly exciting day for the Foundation as we release another study in our signature Regional Market Report series. Our regional market reports are in-depth studies of 7 regions that reflect a range of economic, demographic, care delivery, and financing conditions that we have here in California. You can find this report, which is focused on the Inland Empire counties of Riverside and San Bernardino, on our website at chcf.org. It was just released yesterday. We'll continue to release these reports and conduct webinars like this through the rest of the year and into early 2021. As you see on the slide, our regional market reports are based on original data analysis and hundreds of interviews conducted by the consulting team that's listed in the last bullet there. We're very fortunate today to have the lead author of the Inland Empire Report, Matt Newman, here to briefly highlight some of his findings. We're also joined by the impressive group of local healthcare leaders that you see here on the next slide. Each is here to talk about the unique challenges and opportunities that they're seeing in their communities in the southeastern part of our state. 2 very brief housekeeping items before I turn things over to Matt. First, please do take advantage of the significant expertise that our panel brings by entering your questions into the Q&A box at any time during the next hour. My colleague Lisa and I will be monitoring these questions, and we'll squeeze in just as many as we can after everyone has had a chance to speak. Second, please take a minute when the webinar concludes to help us by filling out the evaluation that pops up on your screen. I can tell you your feedback is very valuable. It will help us with future programming. With that, let's get started. It's my pleasure to turn things over to Matt Newman. Matt is principal and co-founder of Blue Sky Consulting Group and lead author of the Regional Market Report on Riverside and San Bernardino counties. Matt, can you unmute yourself, turn your camera on, and kick things off for us?
I can. Good afternoon, Christoph, and welcome everyone. It's my pleasure to be here with you today, and I appreciate you all making the time to participate in this webinar. With that, why don't we go on to the next slide? So as Christoph mentioned, today's webinar is on one of the 7 regional market studies that we've been preparing over the course of the last year. And these studies have kind of a unique methodology. They're really trying to tell the story of the healthcare landscape in each of these regions. And they combine a range of qualitative and quantitative data to try to tell that story. So over the course of the last year, we've conducted, as Christoph said, for all the reports, hundreds of interviews, 21 of them in the Inland Empire. We've talked to people at health plans and healthcare providers, county governments, and community leaders. And we've collected quantitative data from surveys and from the census and other sources, and looked at news stories and journal articles, and basically everything we could get our hands on to try to understand and then tell you the story of what's going on in the healthcare landscape in each of these regions. Of course, one of the big things that happened while we were doing these reports is the COVID-19 pandemic started. That kind of upended things a little bit, but we shifted gears. We conducted our interviews through a Zoom format similar to this one. And of course, because it's such a big healthcare story, we also included information about the COVID-19 impacts in the Inland Empire as part of the report. I couldn't have done this by myself. I want to thank my co-author, James Paci, and my colleagues from the Blue Sky Consulting Group who all helped edit and discuss and talk about and improve the report, which got published yesterday. Next slide, please, Lisa. So a little bit about the background of the Inland Empire. It's a fast-growing region, growing more quickly than the state of California as a whole. It's home to 4.5 million people. It's divided geographically. On the western side, it looks a little more like kind of more suburban or urban Southern California. And to the east, in the high desert regions and close to the mountains, it's a much more rural area, more sparsely populated and poorer than the western parts of the region. Throughout the region, housing prices are much more affordable than in the rest of Southern California, and that's really driven a lot of the population growth for people moving out of Los Angeles or Orange or San Diego counties trying to find affordable housing in the Inland Empire. The population is younger in the Inland Empire. It's less white, and it's less likely to have high incomes or to have gone to college compared to Californians generally. It's also less likely to have private health insurance coverage and more likely to have coverage from the Medi-Cal program compared to Californians. Next slide, please. And the residents of the Inland Empire, in addition to being poorer, they also report poorer health compared to Californians generally. They're more likely to simply answer a survey question saying they're in fair or poor health. They're more likely to have diabetes or asthma and more likely to be obese or have a preterm birth compared to Californians generally. They're also more likely to report having psychological distress, and the suicide rate is just a little bit higher in the Inland Empire compared to the rest of California. Next slide, please. Healthcare or health insurance coverage in the region is really dominated by two large players. Kaiser Permanente covers about 1 in 4 people in the Inland Empire. And they also are large players in the health insurance exchange covered California and in the Medicare Advantage market. The other large player is the Inland Empire Health Plan. It's the largest of the 2 Medi-Cal managed care plans in the region. And with its 1.3 million members, it covers about a quarter of all the people in the Inland Empire, and it has about 6,000 providers. So it has really a broad reach and a lot of influence over trying to help providers make better use of data and take advantage of pay-for-performance incentives and improve their practice through quality improvement initiatives. Although it is tempered to some extent by the diverse landscape of providers and the decentralized nature of the providers, which we'll talk about on the next slide. In the Inland Empire, people are much more likely to get healthcare from a small independent practice compared to other parts of the state. That is, less likely to go to a large medical group or a large network of clinics and to go to a smaller or independent practice. Although this landscape is changing somewhat, as it is throughout the state, as providers face financial pressures and there's retirements and the burden of running an independent practice becomes more than some providers want to take advantage of. And we're also seeing that new providers just out of medical school are showing more interest in joining a larger organization, a network of clinics or an organization like Kaiser, rather than hanging out their own shingle as might have been more common in the past. That's led to growth in those other sectors and a little bit of a contraction in the independent provider landscape. Next slide, please. One of the things that has coincided with this and perhaps helped accelerate it has been a real growth in federally qualified health centers. This has also been largely spurred by the increase in Medi-Cal coverage stemming from the Affordable Care Act, stretching back more than 5 years now. But the growth has really continued throughout this period up until the current day, with FQHCs in the Inland Empire seeing very substantial growth over the last 5 years. As you can see in the data shown in the table, there's been a 91% increase in the patients per capita in the Inland Empire, compared with just a 30% increase statewide, so a much faster growth in the Inland Empire. There's been a more than doubling of encounters or visits, 137% increase in the number of visits per capita, compared with just a 35% increase statewide. And you can also see in this data that the encounters per capita are about 0.26, which is really just about half of the 0.51 number statewide. So in other words, even as fast as FQHCs have been growing in the region over the last 5 years, there's still potentially a lot more room for them to grow just to get up to where the statewide average is. So this has really been a big increase in access for people in the safety net and a big story that we write about in the report. One thing that hasn't changed over the last 5 years is the clinic operating margins. Clinics in the region still are losing money on average, just as they were 5 years ago. And statewide, this compares to a small positive operating margin, but in the Inland Empire, they're still operating at a loss. Next slide, please. The region is home to 38 separate hospitals, including 12 independent hospitals that account for about 30% of discharges, with the remaining hospitals being part of a small local system or part of a larger statewide or national system. But the hospital sector is very unconsolidated compared to other parts of the state, without having one large or a set of large providers or large hospitals and systems that dominate coverage. So market concentration is very low in the region compared to the rest of the state. That being said, there are some hospitals that dominate their local submarket, particularly in the more rural eastern parts of the region, where there might be just one hospital to serve an entire area. The other thing is that the hospital financial performance has been improving over the last several years, which is good news for the region's hospitals. But some hospitals have closed their pediatric units. This is a trend which predates the time period covered by this report and really stretches back 10 or 15 years or more. These units have been closing for a variety of reasons, some in response to financial pressures, and some in response to a desire to consolidate the pediatric patients in a specialty setting like a children's hospital, or a single hospital system will try to put its pediatric patients together in one area so the staff can specialize. Next slide, please. The region is fortunate to have a health information exchange. Not every region in California does have one. This HIE is called Manifest MedX, and it's really made important strides in connecting providers so that information can be shared between primary care providers and specialists and hospitals throughout the region. It's primarily used so far by the larger medical groups and health centers in the region. It is used by virtually all of the hospitals, so they're all connected to the system now. Several initiatives that the HIE has undertaken to try to, or with help from other players in the region, has undertaken to try to grow its presence. There's been financial incentives from IHP through its hospital pay for performance plan to encourage hospitals to participate. And as I said, that's been very effective. Virtually all the hospitals are now participating. The HIE has continued over the last several years to add new data sources and functionality. It's got claims and clinical data from health plans, as well as the hospital data and data from providers. So it's expanding the kind of data that's covered. IHP is also funding an effort to try to get small providers to participate more, as well as encourage those providers to take advantage of one of a set of cloud-based EHR or electronic health record systems that would be integrated with Manifest MedX, so that right there in the EHR, providers would be able to see the data for their patients that are in the hospital or seeing a specialist. These efforts notwithstanding, there is still an opportunity for improvement, I'll say, with Manifest MedX, or for providers to take more advantage of the opportunity that's been presented to them. Smaller providers haven't participated so far. There's, in some cases, a lack of integration between providers' electronic health record systems and Manifest MedX. And in other cases, when providers have access to the data, they haven't been making full use of it because it takes extra staff time to collect and make that data available to clinical providers. And it costs money to track that data. And so some providers have been slow to take full advantage of the data integration opportunities available to them. In other cases, providers and medical groups and IPAs have set up their own data collection and data sharing systems. Many providers in the region use an EHR called Epic, and providers that share the same EHR or the Epic system in any case are able to see data across providers and share it in that way. Other providers collect their own data and use it to track their patient health and their patient performance and take advantage of the pay for performance incentives. But these things occur outside of the context of the Manifest MedX in many cases. Next slide, please. One of the big challenges in the region is a health workforce shortage. This extends across physicians and nurses and other providers. Particular behavioral health providers and other specialists are in very short supply in the region. This is particularly true in the more remote parts of the region. in the eastern areas. And the reasons for this are manyfold, but one of the biggest ones is that it's just been difficult for the region to compete with more geographically desirable locations elsewhere in Southern California. There's no beaches in the Inland Empire compared to Los Angeles or San Diego or Orange counties. And many physicians simply apparently prefer to live in those areas with their cultural amenities or economic opportunities or access to the coastline. But the region has responded in multiple ways to try to recruit additional providers. IHP has something called the Network Expansion Fund, which pays part of the salary of new providers that come to the region. Many of the interviewees we spoke with are really trying to leverage their own personal networks, talking to friends from med school or people they grew up with who have become physicians or healthcare providers and encouraging them to come to the region. And salaries are higher in the region in spite of its lower cost of living compared to elsewhere in California. So that helps to recruit as well. And then finally, there's been a number of new or expanded medical schools that have opened up in the region or immediately adjacent to it. And it's hoped that these new medical schools will educate physicians that will decide to do residency in the region and ultimately stay and practice there. And many of these schools have incentive programs of various kinds designed to encourage people to stay in the region after they've graduated from medical school. Next slide, please. As I mentioned, COVID-19 happened during the course of this project. Of course, it's perhaps the biggest healthcare story in many decades throughout California, and it's been an especially important impact in the Inland Empire. There have been more cases and more deaths in the Inland Empire compared to statewide, or at least that was the case up through the last time we checked the data just a while ago. Things are rapidly changing, of course. As with other parts of California, unemployment dramatically increased in the region, kind of erasing the gains that the region had experienced since the last recession. CARES Act funding came to the region like all parts of the state, but only at about 2/3 the level of the statewide average. And of course, Medi-Cal enrollment has increased as people have lost their jobs and their health insurance coverage. This has had a big impact on providers in the region. It's put financial pressure on providers and hospitals in the region, as it has throughout California, particularly those providers that rely on fee-for-service. People have not gone to the doctor as much as they might have in the past, particularly in the spring and summer. And providers that rely on that patient revenue have struggled financially. Other providers that rely on capitation, that is, they get a fixed payment every month for a patient that's assigned to their practice, they have done better. But those providers, even though the revenue has continued this year, are concerned about what will happen next year, because many of those capitation payments are tied to performance incentives. For example, vaccination rates. And if patients aren't coming in to get vaccinations, then they won't achieve those performance targets, which could impact their revenue in the subsequent year. Now, health plans are, of course, aware of this, and many of them are responding, but it's still a financial worry for many providers in the region. And of course, the hospitals, in many cases, didn't take advantage of elective procedures trying to make room for the COVID-19 patients, so that's put a strain on hospitals. One of the probably lasting impacts of COVID-19 has been a real big increase in telehealth. Again, this has happened throughout the state, but it's also true in the Inland Empire. Providers have switched to telehealth for things like specialty mental health services, which had not used it very much in the past. And by most accounts, this has been a very positive development. Next slide, please. So finally, we're tracking a number of issues as we look ahead to the future of the region. The evolving physician landscape is an important topic. We want to keep an eye on whether or not independent practices continue to retire and to join with larger groups, or whether this trend stabilizes. We're curious to see if the hospital market will remain unconsolidated, or if it'll start to look more like the hospital market in the rest of California. The FQHC expansion has been very dramatic, but as I said, there's more room for it to grow, so we'll look forward to seeing what happens there. We're tracking whether the region will take fuller advantage of Manifest MedX, its HIE. And we're looking, or I certainly am, with anticipation towards what will happen with the new medical schools that have started and the expanding medical schools, and whether the region will be able to grow its own physicians, if you will. And then lastly, to see what will happen to COVID-19, or to the region as a result of COVID-19, both to the health of the region's residents and to the economy of the region and the financial circumstances of its providers. So with that, I'll turn it back over to Christoph, and I'll look forward to your questions later on in the presentation.
Thank you so much, Matt. That was really interesting, and there's just a lot of information there and a lot of really interesting things to track. I'm excited to turn things over now to a panel of local healthcare leaders for their perspective on some of the issues that you touched on, as well as some of the things that you didn't have time for. Each panelist is going to provide 5 to 7 minutes of remarks on any findings from the report that were particularly surprising, anything that really resonated, or anything else they'd like to highlight. While they're doing that, as a reminder to our audience, please feel free to type in any questions you have for the panelists into the Q&A box on your screen. My colleague Lisa and I will moderate those with everyone after everyone has provided their initial thoughts. So at this time, then, I'd like to turn things over to our first panelist, Dolores Green. Dolores is Executive Director of the Riverside County Medical Association. Dolores, I see you have your camera on. Can you unmute yourself and let us know, how do things look in Riverside and San Bernardino from your perspective?
Well, good afternoon, and thank you for joining us. There was 3 areas that, although the report was excellent and I could talk on all of them, but there were 3 areas that really kind of jumped out at me. The first one is our health information exchange, Manifest MedX. We have such an opportunity here in the Inland Empire to be able to share data no matter where the patient goes. And so we have a very robust HIE. All the hospitals send data, real-time data. The larger practices, again, send the data. Where our challenge is with the 2,000 solo small group physicians that are on probably 225 different types of EMRs. And it really is a challenge to bring on those smaller practices, but it is very important because of the amount of data on patients that's being held in those systems. And so I think what we all need to do is find ways to help the smaller practices be able to participate in the HIE, share data that will benefit the community at large. The state has the CalHOP monies, but I think it behooves all of us to look within our own organizations and say, what can we do and how can we help these smaller practices move on to the HIE? The next area, of course, is COVID. There's been a lot of discussion on COVID. And two areas that I'd like to talk about is the telehealth. And in mid-March, beginning of April, we worked with physician practices, and there was a tremendous shift from seeing patients in physician offices to telehealth. And the physician practices did an amazing job with taking, if you will, unknown technology at that time for the smaller practices and moving to telehealth. But what really helped is being able to utilize telehealth in a number of ways. With the relaxation of the regulations, if a patient wasn't able to do using an iPad or a smartphone or a computer, to be able to talk on the phone with the patients. And that helped tremendously. What is concerning is what's going to happen when the national health emergency is over with. Whether or not the payers and CMS revert back to only paying a pittance, if you will, for telehealth versus keeping the regulations that are in play right now, which adequately reimburses the providers for a telehealth visit. And what we have found is that it does cost as much, if not more, for a telehealth visit because of the time that a telehealth visit is taking, because the patients have more questions and concerns. And so rather than the shorter time in the office, a provider is spending more time with their patients. So I am hoping that the payers will respond to this. It's been a good thing. All the surveys have showed that the patients are loving telehealth. Physicians are still adapting. A lot of them are still, figuring out what their telehealth platform will be. And again, then you have costs involved in that. So again, I think I would encourage the payers to really take a good hard look, and it is a great benefit, and to keep telehealth at the level that we are currently in this pandemic. The last thing I'd like to talk about is really the significant financial impact on the providers' practices. There's again been multiple surveys that done by multiple organizations, and they have all shown that about 81% of practices have reported that their revenue has dropped on the average of 32%. And even with telehealth visits, the visits have gone down about 60% because patients are afraid to seek care, which is the wrong thing, obviously. And it's impacting the doctors who are under a fee-for-service model more than those primary care physicians that may also have capitated patients. And here in the Inland Empire, we have about 60, on average, about 60% capitated patient lives and 40% fee for service. So that 40% is having a significant impact on these physicians. And of course, most specialists, mostly in the solo small group practice, are fee for service. And so their practices have been heavily impacted. And our concern, as Matt talked about, is we already have a provider shortage. And the worst thing that we can have is specialists and primary cares closing down their practices, moving out of the area, or reducing their ability to see patients. And we don't want that to happen. So again, I have to give kudos to IHP. They stepped to the plate earlier in the spring when we approached them with this issue that we saw coming on with the specialists, and they did develop a financial program to help the specialists be able to receive financial assistance to get them through. But now we're in another surge, and so the impact to the physician practices are really, I think, significant. So thank you for allowing me these comments, and I'll turn it back to you, Matt.
Thanks, Dolores. That was perfect. A lot of interesting information there, and certainly many of the things that you've mentioned around telehealth and financial pressures we're also seeing across the state. We're picking up in our surveys that we do of providers across California at the foundation. But next, let's move on. It's my great pleasure to introduce Dr. Takashi Wada. Dr. Wada is Vice President of Population Health at Inland Empire Health Plan. Dr. Wada, I see you have your camera on. Can you unmute yourself and let us know how do things look in the Inland Empire from your perspective?
Great. Well, thank you for having me on the panel. Of course, I think I have to start by referencing COVID. It's hard to have a healthcare discussion without that. It's just putting such a strain on our system and on our providers who are doing an amazing job out there on the front lines. And of course, sympathies go out to anyone who's been personally affected, either physically or financially, from COVID. Turning to the report, thank you, CHCF and Blue Sky, for putting this report together. My first impression is that the Inland Empire has a lot of great assets, but there are some built-in challenges like geography and population demographics. I think overall things are moving in the right direction. There's certainly areas where we can see improvement, and hopefully we can get there by all working together. And so when I think of healthcare systems and I read a report like this, I like to organize my thinking around the triple aim framework. So patient experience, improvement in population health, and then the financial cost perspective. So with the patient experience, I think a lot of times first about access. And so as indicated in the report, the rate of uninsured has decreased a lot because of the Affordable Care Act. That's a good thing. IEHP has 1.3 million members now across both counties. We have independent providers, which give us choice and autonomy. We have IPAs, we have good hospitals, university systems, Loma Linda, RUHS. We have county services, big groups like Kaiser. We have growing FQHCs. So these are all good things for the Inland Empire. But we do have shortage areas, as was discussed previously, in the workforce. And as was mentioned, IEHP is trying to support those efforts, supporting the medical schools that are coming in and medical students. But it's not just about access to care, it's about how that care is delivered. Is it integrated? Is it patient-centered, whole person care delivered in a culturally sensitive manner? Or is the system fragmented? And there are still some areas in our system that are fragmented. But again, I think things are moving in the right direction. We have good communication, coordination with the counties. We have FQHCs that are growing and integrating care. We just recently found out about a $32 million grant coming down to the Inland Empire for behavioral health integration from the state via IEHP. So that will help to spur improvements and better coordination and integration on the physical health side and the behavioral health side. Are we also meeting patients where they want their care? The old model was that the patients had to come to us, but I think we have to continue moving that in the other direction and getting the care out to where our members are, either through mobile in-home offerings, remote patient monitoring, and was mentioned earlier, telehealth. That was certainly accelerated under COVID, but it's something that's going to be here to stay. And I think there are a lot of pieces of healthcare delivery that can move to that telehealth, telemedicine model. Thinking of improvements of population health, for IEHP, we track HEDIS metrics. These are different rates of screening, preventive care, disease management. And again, I think we see areas where we're moving in the right direction and other areas where we're not moving as quickly as we like. And so there are definitely areas for improvement there. And thinking about how to get to those higher levels of quality, we really have to think about systematic issues. Do we have the infrastructure? Do we have adequate, timely, and integrated data, as Dolores was talking about Manifest Medics and electronic health records? Are there gaps along our continuum of care? So an example there, there's a lack of inpatient psychiatric beds across the state that create challenges. How are the transitions happening? What about an equity standpoint? Are there subpopulations that are not doing well? Areas where we need to focus more on social determinants of health, not just the healthcare that's delivered within the walls of our healthcare system, clinics and hospitals, but what's going out in the community and all these other upstream influences on health. And then on the financial side, on the cost side, if you have good access, if you have quality, if you're addressing social determinants, you don't have gaps, transitions are happening, patients are getting the right care at the right time, at the right place, then we should be getting good outcomes and better value for our healthcare dollars. So, I'd like to sort of highlight maybe a couple areas where IEHP is really thinking about currently and into the future. One is in the value-based care and really trying to move the needle on quality on the Medicaid side or the Medi-Cal side. Really just continuing this journey from volume-based reimbursement to value. It's certainly already happening on the Medicare side with MIPS and alternate payment models. And so for IEHP as a payer, we're not the ones out there delivering the care, but we do have tools that we can use to improve quality. So we can reimburse through incentives, pay for performance, assigning members based on provider quality. So these are all things that we can do to try to help move the needle. All of these things, though, depend on really robust data systems. So IEHP is helping our community providers get onto electronic health record systems. We have to do more in the way of predictive analytics, risk stratifying to better target interventions, providing gaps in care reporting to our providers so they know what type of care is missing, having disease registries. And so right now, in terms of value-based care, we're moving again in the right direction. I think we're doing a lot of these things to try to incentivize providers who already want to do the right thing, but maybe they just need a little bit more resources. Not quite, I think all the way downstream on value-based care in terms of global capitation and things like that, where everything is sort of bundled together and there's upside risk and downside risk. We're not quite there yet on the Medicaid side, but again, we're working to try to move the needle on quality. And then the other area that I'd like to reference is around social determinants. And so Cal-AIM is the state's Medi-Cal sort of waiver proposal to refresh Medi-Cal. There are a lot of components of that around complex care management, around what's called in lieu of services, which address and provide funding for some of the social determinant type programs, whether it's housing, food insecurity, in-home supports to avoid institutionalization, home modification. So these are all things that we're looking at that are being proposed. Again, because of COVID, Cal-AIM implementation was kind of put on hold. We're not exactly sure how it's going to come back, but we're very hopeful that these things can come back. And there are other pieces of Cal-AIM as well that we're really working to promote integration between behavioral health and physical health. So a lot of good things in there that we'll be watching very closely and hopefully implementing over the next years. So with that, again, thank you, and I'll turn it back over to Christoph.
Thank you so much, Dr. Wada. That was great. Certainly lots of things you have going on over there at IHP and lots of good work for sure. Finally, we're privileged to have Jody Wingo join us. Jody is the president and CEO of Community Health Association, Inland's Southern Region. Jody, I see you've got your camera on. Can you unmute yourself and let us know how do things look in the Inland Empire from your perspective?
Thank you, Christoph, and thank you for inviting us to be a part of this today. It's a privilege, and thank you, CHCF and Blue Sky for the report that you did. I think it's incredible. As my colleagues mentioned, there were some things they were talking about that, of course, jumped out at me, and talking about it from a provider and federally qualified health center perspective. I want to say that, the future for us is very much what Dr. Wada was just talking about, focused on quality and value-based care. I'm looking forward to us working with Kaiser and with IEHP on quality measures going into the new year and, moving HEDIS measures in the right direction. We're also looking at how are we going to do quality improvement in a telehealth world, because it looks a little different than what we're used to, and most of our members are not in the space yet where they've been able to afford getting into remote patient monitoring and things like that. So those are all things that we're going to be exploring at length and seeing how we make that happen. The other thing that we are going to be, or we are working on already with the state and California Primary Care Association, we're doing a lot of advocacy and are at the table in terms of the pharmacy transition that the governor has put into place, which was delayed until April, but we are looking at the savings from our 340B drug program potentially going away or being replaced. And those are funds that many of our members use to fund programs that don't get reimbursed, like our homeless programs and, our migrant farm worker programs, our undocumented programs, things of that nature. So we're going to be doing a lot of work around that, as well as payment reform and working with the state on alternative payment methodology and things that might work to kind of, revamp or re-energize the whole Medi-Cal system and how we're getting paid. One of the things that we're dealing with, obviously, right now, quite a bit, is the fact that the pandemic has caused even further staffing and provider shortages than we were already dealing with. We talked earlier about how recruiting physicians to the Inland Empire is a challenge due to the geographic nature of where we're at. But when you're in FQHC, it's even more, challenging, because we're not able to pay the same salaries as other types of maybe funders can or payers can, and even the amount that they could be making possibly as an independent physician. So we're going to be working a lot with the medical schools. We work closely with UCR, CUSM, Loma Linda, and hoping to be working with Kaiser as well about ways to, work with young medical students, have them go through our community-based healthcare program, and maybe intern at our health centers or do the residency at health centers, hopefully making that community-based healthcare connection so that they will stay with us here in the Inland Empire. So we'll be doing a lot of work that way. Very focused, obviously, on social determinants of health and healthcare disparities. So we are initiating several work groups alongside UCRCSI to address healthcare disparities in the various regions of both of our counties, working with our rural health centers who are experiencing challenges with telehealth due to the digital divide, and many of our patients in the rural areas not having the same sorts of access to iPads, telephones, internet service that our patients in other areas of the Inland Empire have. So trying to come up with solutions for that. And the other thing that is right on the top of our list is advocating for continued funding. FQHCs get 330 funding from the federal government, but it's not something that is done on, it's done on a 1 year or 2 year basis. Right now, that funding cliff is about to hit us, and we're advocating for continued funding, which, hopefully will get extended for another year or two. So it feels like we're always kind of in this, advocating not panic really, but, always working to try to ask for funding to continue so that FQHCs can continue to operate and serve those Medi-Cal patients, particularly out in our most rural areas. And behavioral health integration, I think you'll continue to see a lot more of that. We have a couple of members that have done a very great job of integrating behavioral health into their primary care practices, but we're working with all of our members that are able to provide behavioral health and substance use disorder treatment to really integrate that into the primary care that they're offering. And then lastly, the other thing I'll say is we're working really hard with Dolores and her staff to get our FQHCs up and running with the Manifest MedX. We're in with that situation that was described earlier where we have 19 members. And I think between our 19 organizational members, there's probably 11 different EMRs. So it makes it challenging when you're trying to do quality improvement work or do data exchanges with the payer sources like IEHP. So we're going to continue to work on that. I think the future for us hopefully will look like, all of us being connected and able to share information between the hospitals and the FQs and the private physicians and the payers, and be able to provide seamless continuity of care to our patients. And hopefully, be able to establish medical homes for patients so that they're not over utilizing our emergency rooms and our urgent cares. So I know I tried to get a lot in about 5 minutes. So I'm here. If you guys have any questions, then I'll stop talking now. Back to you, Christoph.
Jody, it's all really interesting. Great job. And at this point, let's use our remaining time here. We've got about 15 minutes or so for a general Q&A with you, Jody, and the entire panel. So I'd ask Jody, Dolores, and Dr. Wada, please turn your cameras on and unmute yourselves. As a reminder to the audience, and Matt, thanks. As a reminder, anyone out there, please put your questions in that you have for our panelists into the Q&A box, and we'll do our best to fit those in. I know we've had a number of questions come in already. Lisa, do you want to get us started with the first one?
Yeah, this is a two-part question on fee-for-service. Can you say, and it seems to be directed to Matt, can you say more about the financial struggles of fee-for-service providers? Is that a Medi-Cal issue or private insurance? And continuing that some sources have indicated that there were issues early in the pandemic, but the utilization was normalizing, at least before this current wave. Any other information?
So there's a lot there. So Matt, I'll let you take the first swing at that. But, I know Dolores, you also touched on that in your remarks. I'd like to get your perspective, and Dr. Wada, if you wanted to too. But Matt, why don't you take that one first?
Yeah, I mean, I think Dolores probably knows much more about it than I do, but in general, I think this spans both the Medi-Cal and the commercial insurance world. I think it was a bigger issue early in the pandemic, but as Dolores mentioned, we're in a second wave now, and I haven't done any research in the last month on what's going on with providers, but I strongly suspect that many people are staying away from the doctor just as they did earlier in the spring. So I think it really spans the landscape. But Dolores, I'd be curious to hear if you have any additional information.
I would agree with you, Matt. The numbers still are not up to where they were post or pre COVID. Patients and rightly so are concerned about seeking health care in offices. However, I think the biggest message we can convey to patients is to call their doctor and schedule a telehealth visit. Or, of course, if they're having major issues, breathing, etc., to make sure that they call 911 or go to the emergency room. But again, what we saw even in July and August when additional surveys were done, the number of visits were still down significantly, about 35 to 40%. And then, of course, now with the surge, that's going to further, I think, reduce patients wanting to seek healthcare when they really need to take care of their health. So our message and all of our messages should be to the patients to make sure that you are seeking the care that you need. And there's many ways to be seen rather than physical. And so it's important that they do call their provider and schedule a telehealth visit. Or if they do need to be seen, the doctor's offices as well as the hospitals are very safe places. They've taken additional measures, utilizing PPE way more than what has ever been done in the past, and it is safe to go to the doctor.
Thank you for that, Dolores. Dr. Wada, I want to give you a chance to jump in here if you'd like, but I'm just curious, what are you seeing around utilization recently, and what are you seeing in terms of the struggles of fee-for-service providers in particular?
For IEHP, most of our primary care network is capitated, and so if this would be more of an issue, say on the specialist or hospital where we try to work with them. Same thing as was already referenced. I think initially there was a big decrease in utilization as everyone tried to ramp up and see what could be done through telehealth. But we've been seeing that gradually increasing, probably still not back to pre-COVID levels, but increasing.
And then Jody, I want to give you a chance to, what you mentioned a little bit in your remarks about kind of the utilization drop. What are your members seeing recently?
Thank you. I would agree with what Dr. Wada and Dolores both said. I mean, some providers are back up to maybe a 60 or 70% productivity, but definitely not back up to pre-COVID numbers. And before this last surge, they were starting to try to do some things via drive-through, even testing out drive-through immunizations and things like that could be done that way without patients having to actually bring their children in. So, they're trying to get creative, but yes, we're still definitely down at least 20, 25%.
Yeah, thank you all. Let's move on because we do have a number of questions. Lisa, do we have another one to go to?
Yes. Do the health plans interviewed include mental health plans and SUD plans for the public system?
That's great. That sounds like a methodology question that I want to direct to Matt, and then maybe we'll take some of these questions around that have come up around behavioral health. But just first on methodology, Matt, any thoughts there?
Yeah, absolutely. We spoke with people from both Riverside and San Bernardino County, and behavioral health is a huge issue in the Inland Empire, as it is throughout the state, really. There's a little graph in one of the slides I showed, which shows that the region has many fewer psychiatrists per capita compared to other regions in California. And the recruitment difficulties in behavioral health are as bad or worse as they are in any specialty in the region. Both counties are working on efforts in various stages to integrate behavioral health and physical health. And so that's a positive sign for the future. although there's still challenges in the Medi-Cal program integrating behavioral health and physical health and sharing data among behavioral health and physical health providers. And both counties continue to struggle with those limitations as well.
Lisa, I know there were a number of questions about health and social services.
There's one here. What is the Inland Empire doing to connect health and social care, and what can we do to improve?
That's there we go. So, I know Jody, you touched on this, and Dr. Wada, you touched on this. Do you both have thoughts about that? What is, when you look at Riverside and San Bernardino, what are the main sort of initiatives right now to strengthen those connections, and where are the real opportunities for improvement? Jody, do you want to take a swing at that one first?
Sure. We are definitely seeing the FQHCs, almost all of them in our membership, are doing population health screenings when their patients come in. So they're screening for social determinants of health. Even as people are coming in for COVID vaccines, we were trying to do, and we had some success until now, this surge, and everyone's so overwhelmed and no one wants to stand in line and ask, fill out questionnaires about things that they're just there for their tests. But we do, for every patient that we see, gather social determinants of health information, and then we connect them to services in the community, whether it's through, community partners that we have, or using Connect IE, which is an amazing resource that we adore. So yes, we do try to address those social determinants of needs as well.
That's great. And Dr. Wada, any thoughts on that? Kind of, big initiatives and most opportunity for improvement?
Yeah, I would certainly echo the importance of addressing social determinants of care. These upstream influences just have tremendous impact on our populations, particularly in Medi-Cal. So hopefully with the CalAIM, the state's CalAIM proposal, there'll be mechanisms to do that. IEHP already is doing some work in the housing space, but with CalAIM, hopefully that will expand with additional housing supports, as well as opportunities for food and other types of social determinant work. So it's certainly not something that any one of us can address individually. It's got to be a collective impact, and everybody working together, exchanging information, coordinating, so that we make best use of our existing resources, and then identify gaps that we can then try to work together to address.
Thanks for that. Let's try to squeeze in a few more of these questions. I know there's a couple on workforce in there, Lisa.
Yeah, there are a couple questions. There's actually two on nursing, bed to staffing and nursing, and also there's a question about which also relates to workforce. Both could be discussed. It would be interesting to hear how the IE compares to the state for psychiatric inpatient care. So those are some workforce questions.
Yeah, so maybe on the psych inpatient care, Dr. Wada, you had touched on that in your remarks, and the shortage there in the Inland Empire. Do you have any more to say about that?
I know this is an issue that's really statewide. I know, sort of from our work here at IEHP, the system for behavioral health is fragmented, and so the higher levels go to the county for severe mental illness, and then the health plan gets sort of the mild to moderate. But we do still hear that there are challenges related to inpatient psychiatric beds. Again, I believe this is sort of a statewide issue, especially for children and youth inpatient placement. So it's something very, very challenging.
For sure, and I apologize, but I will promote a report that CHCF put out back in the spring about some of these challenges throughout the state. So certainly, what your general remarks there, I think, Dr. Wada, are very consistent with what we found in that report. When it comes specifically to workforce, there were the questions about the nurses, and so if there's anyone on the panel that would like to handle that, certainly. Happy to hear your thoughts. I would also, I know Dolores, you had touched on a little bit sort of the new medical schools, and we do have a question from one of the panelists about residency slots. And so I'm curious if you and your members have a perspective on the availability of residency slots, and those, which do you see as being in particular short supply? Where are the greatest shortages for the Inland Empire?
So, what has happened, which is great news, in that the number of our residency programs in the Inland Empire have increased significantly in the last 5 years, and a lot of that is through partnerships with the hospitals and residency programs, but the funding of the residency programs, whereas traditionally it was all funded by the government through Medicare. And so we have seen an increase, but again, the key is keeping those residents in the Inland Empire. And so a lot of work is being done to connect the residents, if you will, under mentorships or engaging their families. So a lot of different ways, because we know that normally where somebody does their residency is where they have a tendency to settle down. They by that time have gotten married, maybe having children, and they're ingrained in the community. And that's what we really work hard to try and keep the residents. And with the funding now through the tobacco tax, there is funding for loan forgiveness, which has gone a long ways to helping young physicians repay their loans. But we're still seeing, again, psychiatry has a huge shortage, primary care, some of the surgical practices. So for the Inland Empire, it's almost every single specialty that has some shortage. And Dr. Wada, do you have anything to add to that?
Could be addressed.
No, I mean, I think it's great that we have more medical schools coming online and graduating more medical students, and hopefully they can stay in the area. And IHP has really worked to try to support those efforts. But yeah, this is definitely a challenge getting the provider population ratios up to where we'd like them.
You guys, I could talk to you all afternoon, but we are running short on time. So I'm gonna exercise sort of moderator's prerogative here and choose a last question before we close things off. But this is kind of a forward-looking one. I'll ask all of you and Matt as well. If we were, hypothetically, if we were to do this study again in 3 years or 5 years, I'd be curious what change in the Inland Empire and the delivery system in the Inland Empire would you hope to see, and what change are you concerned about seeing? When we look forward in 3 to 5 years, what are you hopeful for and concerned about? Jody, I'll let you kick us off.
The first thing that popped into my mind is I hope you will see an Inland Empire region that is all connected somehow, whether we manage to all get on the same EMR, which would be a miracle, but I like to dream, or we are all using a platform like Manifest MedX where we are all interconnected and we're providing the best possible continuity of care for our patients. So that's what I would dream that we'll be able to see, and working together on quality initiatives and things of that nature. What my concern is when it comes to our members and the FQHCs is continued funding. I'm concerned because it is such a short-term solution that we have right now, and I'm hoping that in 3 to 5 years you might see a more permanent solution to the funding that our members need, but that would be my biggest concern.
Thanks. Dolores, 30 seconds. What are you hopeful for and what are you concerned about?
Well, I'm hopeful for the direction that we're moving to value-based care and to team-based care. I think it's really important. We're not going to be able to solve our workforce issues and just there's just not enough physicians for that. But moving into team-based care and value-based care and taking care of the population, I think will go a long ways. My concern is that as our changing demographics and potentially more and more patients being seen under, say, Medi-Cal, and the reimbursement that is there is not going to be enough to support our system here in the Inland Empire.
Dr. Wada, 10 seconds. hopeful and concerned about it.
Sure. I mean, same thing. I'd like to see improvements on the data side, just, comprehensive data coming in. The more information we have about our patients or members, the better, so that it's integrated. More work on social determinants of health, through CalAIM or what other mechanisms might be available to really help support addressing those upstream issues and getting, community health workers, promotoras out there, really building trust in the community, and trying to work towards just a better healthcare system overall.
That's great. And Matt, you got 5 seconds. Hopeful and concerned.
I'm hopeful that the behavioral health integration efforts that have been underway for the last many years will succeed and further and continue, and will get people that have behavioral health and physical health needs to get their providers talking to each other and improve their care. And my concern is that the impact of COVID on the economy and on the provider landscape and on the residents of the Inland Empire will be lasting and severe, and I hope we're able to overcome that challenge.
Thank you all so much for your time this afternoon and your perspective. This has been tremendously interesting and really thought-provoking, so appreciate it. A note to our audience, this is the second of 7 webinars and 7 reports that are doing. The next report on the Central Valley will be coming up in a few weeks here, and registration information for the webinar and that report will be available on our website shortly. And just a quick reminder, please do take a minute to fill out the evaluation that's going to pop up on your screen in just a minute here. So I'll close with a thank you to all of our panelists. Thank you, Karen, Angie, Scott, the whole Golden State Health Policy team and CHCF team that helped pull this webinar off. And thank you everyone in the audience for joining us. I learned a lot this afternoon and I hope you did too. Thank you, everyone. Have a great day and we'll see you next time. Bye-bye.
Thank you.
Bye-bye.